Hello everyone, my name is Evy Cleeren and I'm currently appointed in the University Hospital in Leuven in Belgium as the coordinator of the multidisciplinary epilepsy surgery unit, in which my main role is the involvement in the multimodal imaging, so mainly the post-processing of all these images during the pre-surgical evaluation and epilepsy in our center. And today I will talk about ictal SPECT in epilepsy. To start, I would like to play a short video clip to show you what ictal SPECT is all about. So this is a video over EMU. Here the seizures start based on EEG, and soon you will see one of our epilepsy nurses running in. And there she is. She takes the syringe and she injects the radio tracer while the seizure is still going on. So if we look at this scheme about the pre-surgical evaluation in epilepsy as proposed by Rosenau and Luders, we see that ictal SPECT is situated here as the method to image the ictal onset zone, so the part of the brain where the seizure starts. The principles of SPECT. SPECT stands for Single-Photon Emission Computed Tomography, and it's a functional neuroimaging technique which belongs to the nuclear medicine department, which means that we are working with radioactive isotopes. In this case, gamma ray emitting isotopes that are labeled with 99M technetium, which has a radioactive decay and a half-life of 6.1 hours. In our center, we work with a triple head camera, as is shown here on the picture and here in the schematic overview. So the subject is in between the three camera heads, which are quite close to the head, and these cameras rotate around the patient. To image brain perfusion, several tracers can be used. And the most common one, or the most known one for ictal SPECT, are both 99M technetium labeled, either ECD or HMPAO. Both of them are neutral lipophilic complexes, which rapidly can cross the blood-brain barrier in a way that it's proportional to the cerebral blood flow. Then they undergo a hydrophilic conversion, which makes that they remain trapped in the tissue for at least several hours, which gives us the advantage that we have some kind of frozen distribution, that we can make a snapshot-like image of brain perfusion as it was during injection of the tracer, but at a later time point. Several studies compared different tracers. Both of them has their advantages and disadvantages, but a quite recent study of 2001 showed that there was actually no evidence to favor one above the other for the purpose of the identification of the seizure onset zone. In our center we use ECD, and here you see the time activity curve of ECD in the human brain after IV injection in the arm. So you see that it takes about 20 to 30 seconds for the tracer to reach the brain, and then there is a steep uptake phase which reaches its maximum at around 1 minute. So this means that this frozen image we are making is weighted primarily towards the first 30 to 60 seconds after injection. Then if we see how long this tracer remains stable in the brain, or the brain uptake, we see if subjects were scanned at several time points after injection, that up to 4 hours we have a quite stable image, a similar image of the brain. So this means that we have 2 to 4 hours for sure, that's the time between tracer injection and scanning of the patients. So this is all the time that we can use, or sometimes we need, for patient stabilization, to stabilize the patient after a seizure, to make sure that the patient is fully awake and cooperative. Also for patient transport from the epilepsy monitoring unit, where generally the ictal injection happened, to transport them to the nuclear medicine department. In our center, the two departments are in the same building, but there are other centers where injection happens in an epilepsy center, and then the patient has to be transported to another building or to another city to undergo the SPECT scan itself. Then the setup, different centers have a slightly different setup, but injection of the tracer always happens during video EEG monitoring. And you want to inject as early as possible during a seizure. One of our colleagues checked retrospectively several years ago, and we had in 92 ictal SPECT scans, we had a median injection time of 20.5 seconds with a range from 2 to 116, with the vast majority of the injections happened earlier than 30 seconds. This injection has a is unpredictable in many ways. So you don't know when a seizure is going to happen, so you need constant monitoring. Then when you detect a seizure and you start injecting of the tracer, you have no idea how long the seizure is going to take after injection. You don't know how the seizure will evolve in terms of seizure type and semiology. So these are all very unpredictable factors. In our center, we have the availability of the tracer from Monday to Friday from 8:30 till 4:30, and we get a fresh dose of radio tracer delivered at the EMO at 8:30 and at 12:30. When you have an ictal SPECT setup, or if you want to start an ictal SPECT setup, you need to be aware of all the radiation protection rules. So in our center, the tracer gets delivered in a lead box to limit the exposure of the irradiation to both the patient and the visitors and the nurses. Through different valves, it gets connected up to the IV line of the patient. So here you would have the IV line of the patient going towards the patient. And it's developed in such a way that the epilepsy nurses, they never have to open this box, so they never get a direct exposure. So if they would press this syringe with saline here, through different valves, the tracer will be injected into the patient. Also because you never know when a seizure is going to happen, so when you can inject, also the injected dose is quite variable, which will be calculated afterwards because the radiopharmacy department, they know the starting dose and they know the timing of the injection. But this can also affect the image quality. So if you inject by, like in our case, at 4 in the afternoon, there is a bit less activity in the tracer, so in the scan. So the scans are sometimes more noisy and might be a bit harder to analyze. In our center, injection is performed by a trained epilepsy nurse. So here there is a picture of our monitoring setup. So our monitoring room is in between the two rooms where we can perform ictal SPECT. So generally we have 2 patients for ictal SPECT, in which we have continuous monitoring of the EEG and the video here for the first patient, here for the second patient. Then on top of that, we have 2 patients for 24-hour EEG, in which we also have live monitoring. And in the meantime that the nurses are monitoring the 2 patients, they are doing a first read of the EEG of the day and the night before. So this is multitasking at its finest. So there is continuous monitoring between like 8 in the morning and 10 at night, in which we can do an ictal SPECT injection till 4:30 in the afternoon. Exceptionally, injection can also be informed by the patient himself. So here is an example of a patient who had the typical textbook insular seizures. So he would notice the sensation in his throat and he would inject himself. In this case, the patient was an 11-year-old boy whose seizure started with pain. So he would shout because he would be in pain, the father would inject the tracer and the mom would press the alarm button to notify the nurses, who are at the same time also monitoring. So even if caretakers or patients inject themselves, the moment they start injecting, the nurses are there like a few seconds later. In our setup, we always train the patient or the caretakers so they have a feeling about how hard you have to press to inject and so on. So this is rather exceptionally. Then if you look at the literature, there is also quite something going on about remote control injectors, which means that from the monitoring station you could press a button which will start the injection. These are pictures of a quite recent paper from the group of Barcelona, which used the commercially available EpiJet system. We don't have any experience with it, but it's for sure something to look into, to be able to have even more early injections happening. So you want the set to inject as early as possible during a seizure. This is very resource demanding, so you need staff that is very well trained, who needs to be monitoring the patient non-stop, and they need to be trained to recognize seizure patterns very early. In our center, our monitoring room is next to the patient room. In other centers, IMU nurses or technicians are actually sitting next to the patient every moment that the tracer is available, which would even make it even more resource demanding than in the setting that we are working. But this will potentially lead to earlier injections. In a study from Lee et al. In 2006, they concluded that if you inject earlier than 20 seconds after seizure onset, that this was significantly correlated with cord localization. But 20 seconds, it's already rather fast. You preferably want to inject during a focal impaired awareness seizure, because in our hands we saw in the past that during focal aware seizures that ictal SPECT gave no localizing information in about 40% of cases. And this also kind of limits the self-injection of the patient, because generally patients who would inject themselves would be during focal aware seizures. You have to be aware of the post-ictal switch, so it means that the region which has an increased perfusion during the seizure, this will switch to hypoperfusion in the post-ictal phase. And in temporal lobe seizures, it's known that this occurs 1 to 2 minutes post-ictally, so you have a bit more time to inject for temporal lobe seizures, but this post-ictal switch is much shorter in extratemporal lobe seizures. And Kaminska et al. In 2003, they saw that extratemporal lobe seizures should last for at least 10 to 15 seconds after ictal SPECT injection in order to give localizing information. But this, again, like I said before, this is something the moment you detect the seizure and you inject, you have no idea, or you don't know beforehand how long the seizure will last. But this will be very important in the interpretation of the results later on. If you are in a center where you have the possibility to acquire a second ictal SPECT scan, you need to make sure that the time between 2 injections is about 5-6 times the half-life of the tracer. So in this case, about 36 hours. So in our center, if we are very lucky and we can inject a seizure on Monday, on the first recording day, we would have a resting day on Tuesday, and we could try do a next attempt to get a second ictal SPECT on Wednesday. Then next to the ictal SPECT, you also want an intraictal SPECT, which is the same but injected at a moment that the patient is not having a seizure. In some centers, this sometimes happens at the end of the monitoring period for the ictal SPECT. So if at the end of the monitoring period you were not able to catch a seizure, in some centers then they would inject a tracer to use it as an interictal SPECT. In our center we don't do it like this because we also don't have, for ictal SPECT scanning, we don't have fixed scan slots. So in our department, when we inject a patient for ictal SPECT, we call the nuclear medicine department and they will pause their clinical workflow and they will scan our patient first. So for our interictal SPECT, these are ambulatory, so these are planned scan slots. So this happens at the nuclear medicine department, also under video EEG monitoring. So we monitor from several minutes before the injection until several minutes after to make sure that it's a true interictal injection. This happens under standardized conditions, so patients are in a dimly lit and silent room, laying into a bed with their eyes closed. Very important is that the technical aspects should be the same as during the ictal injection. So you want to use the same type of tracer, which was prepared in the exact same way. You want to use the same camera, so the same scanner, the same acquisition protocol, and the same image reconstruction. And this is all to minimize the technical differences between the ictal and the interictal scan. Because later we will compare ictal and interictal, and you want to make sure, or you want to minimize the chances that the differences that you see, that this will be due to technical aspects rather than to real changes in brain perfusion. For the analysis, you always start with a visual assessment, then you can go one step further and do some quantifications. There you have different options. You can go on without the use of a control group, which entails a SysCom analysis, which stands for Subtraction Ictal Spectral Register to MRI, which can be done by MATLAB and SPM-based routines. There is also an open source MNI SysCom tool, which is actually very easy to install and very fast to use. Several commercial softwares also have SysCom routines. So in MIM Neuro, there is a SysCom routine, which is standardly used in our Department of Nuclear Medicine. Also, the morphometric analysis program of Professor Huberts also has a SysCom module. If you want to go one step further and you want to check whether the differences between the ictal and the interictal scan that you see, if those differences are also statistically relevant, you need to start working with a control group. There are several algorithms or programs available. So this ISAS, it's available open source through the Bioimage Suite, which is less straightforward to use than the MNI SysCom, but they have very well an extended manual, which you can follow step by step, which makes this also a rather fast method, or you get results quite fast. Another rather similar algorithm is Statisticom, and probably there are many more. So in the remainder of my talk, I will only talk about SysCom analysis using MATLAB, SPM, and a subtraction routine that was written by Professor Patrick Dupont from our department, in which he was kindly enough to allow me to share it with all of you. But before we go into the different steps of the analysis, I would like to show you or introduce you to a first case. So this is a 32-year-old male with epilepsy started at the age of 26. His semiology of the seizures, he describes it as a rising epigastric sensation. He will become pale, and it can be followed by impairment of awareness, oral automatisms, or some other movement. This seizure happens 2-3 times a week. Interictal and ictal EEG point to the right antero-mid-temporal cortex. The MRI showed on the right the anteromedial temporal cortex. showed a blurriness of the gray matter-white matter junction, which is shown here in this image, and a slightly enlarged amygdala, which was also confirmed with the morphometric analysis program. FDG PET showed a mild hypometabolism in the right anterior temporal cortex as well. So here I squeezed together 1 minute of EEG, which contained the seizure of this patient. So seizure onset on the EEG was here. Injection started 13 seconds after the first EEG changes, and the whole seizure took, correlated to EEG, 52 seconds. Semiology was staring, motor arrest, ictal speech, and discrete oral automatisms. And the EEG changes, which are shown here in a longitudinal bipolar montage, you see changes in the right anterior mid-temporal leads. When you acquire your ictal and your interictal SPECT scans, you always start with a visual assessment. And in theory, your ictal SPECT scan will show hyperperfusion, so an increase in perfusion in those areas that required more energy during the injection. So where the seizure was happening, and potentially also in areas of seizure propagation. In the interictal SPECT scan, you would expect a hypoperfusion or even a normal perfusion in the epileptogenic region, which kind of limits the use of an interictal SPECT on its own. So these are the scans of our patient. We see here a hyperperfusion in the right temporal lobe, rather extensive. If we look at the interictal scan, you might see a very slight hypoperfusion in the right temporal lobe, or even you can consider this as a rather normal perfusion. Interpretation of these images, this relies heavily on the experience of the reader. So in our center, this visual assessment is done by the experts of nuclear medicine. Then we go to the SysCom analysis. I will show you here the overview, then we will go through it step by step, and in the meantime we can run an analysis together in MATLAB and SPM. So you have an ictal and an interictal scan. You co-register them together so they match. Then you want to normalize for global counts because there was most likely the injected dose was different between the ictal and the interictal scan, so you have to account for that. You will subtract the images, smooth them, and convert them into z-scores. Then you will get a z-score difference image like this. Then you will co-register the 3 of them to the MRI. So you will end up with the MRI, the ictal, the interictal, and the difference image in the same space. And you can load the difference image as an overlay on the MRI to obtain your SysCom image. So the software that you need to do this analysis is you need MATLAB and you need SPM. And you need a viewer to be able to view your results and to double check and do a quality control check on all the in-between steps. I like a lot MRI cron, so I will be using this in the remainder of the talk. There are also a lot of other all open source options. So you have the MRI Crow GL, Mango, SPM, SPM plugins, ITK Snap, MRView, FSLIs, and so on and so on. So if we start at our SysCom analysis, the first step is to co-register the ictal and the interictal SPECT scan. SPM works with images in Nifty format. Generally, when you download the scans or export the scans from the scanner, they are in DICOM. There are also many tools to convert them. So you can use SPM, you can use DICOM to Nifty tool, you can use MRI Crow GL, and so on and so on. The only thing that if you start doing this, you need to be aware of the orientation. So you need to be sure that during these conversions, left-right doesn't flip. For clinical scans, this is generally not a problem. I worked before in preclinical studies, and there with animal scans, sometimes, or in the micropet or the microspect, sometimes the orientation would flip, so you need to be aware of this. Then we can go to MATLAB. So you go to MATLAB through the folder where you have your MRI, an intraictal and an ictal scan. Before you start, you do a quality check on your images. So you open them, you see if they are correct, if they look okay, if the field of view was big enough. And you can do this with this check registration. So you open all 3 of them. And you can scroll through and you see that the images look quite nice. So now when we want to co-register them, what I do to help SPM is to actually like rotate and translate the images a bit, so to give them the same orientation and the same similar origin, so that the co-registration by SPM, that it will be easier and be more have a higher chance of success. So I do this, generally I take the MRI, the origin of the MRI and the orientation of the MRI, and here the MRI is quite straight, and the origin is somewhere here in the thalamic region. So then I will apply the same to the ictal and the intraictal scan. So you see this scan also, it's positioned, the patient is positioned quite nicely, and I will put the origin in a more or less similar position as in the MRI. And now here where I put the crosshair here, it gives the position here compared to the current origin. So this is 2.8 millimeters away from the current origin. So if I want to change this, I will put the opposite value in here, the right forward up values. So here it will be minus 2.8 and 0, 0 is fine. So if I want to double check and I put here 0, 0, 0, I go to the new origin, which is here. Then I have to reorient them. I'm working on the ictal scan. I'm not saving this transformation matrix. And I will do the same for the intraictal, in which the positioning is also quite okay. We could rotate maybe this one a little bit like this. Also, when you rotate, be aware that SPM works in radials, not in degrees. Then we go back. We want to set the origin around here, and then we take the opposite values of these. So it will be 0, it will be 9.8, and it will be minus 41.4. Double check. It's there. You reorient. The intraictal, you don't have to save this transformation matrix. And you can check again, and you see now that in these images that they are at least a bit closer together than they were before. So then, to co-register the ictal and the intraictal SPECT, we use the co-register estimate and reslice batch, and then it actually explains itself very well. So the reference image is the image that is assumed to remain stationary. So it's a template or the target image. So in our case, it's the intraictal. I always use with the intraictal as the reference image because, as I said, in our center, we acquire this ambulatory. So the patient is getting like a fresh dose of tracer. So generally the quality of the intraictal scan is better and it's more evenly distributed than for the ictal scan. Then the source image is the image that is jiggled around to best match the reference. So this is the ictal. And then all the other options and values, you can keep them the standard way. You run it. While it's running, you can already close the batch and you don't need to save it. So this normally doesn't take too long to run. So there we get the results. And you see here in the joint histogram that the two scans are more equal now as they were before. So then we quit this one, and then it's very important that you double check whatever MATLAB is giving you as an output. So here I will open in MRI Cron the intra-ictal scan. And SPM always writes the co-registered scans with an R in front. So we add this co-registered to the R ictal on top, and we threshold it a bit, and we see that the co-registration is actually good. I also like a lot this tool of the wizard head, where you can see the differences. So sometimes the co-registration of the ictal and the intra-ictal might be like a little bit rotated, which you can then easily see if you use this wizard head. But this looks fine. So then we can go on. So before co-registration, we have the scans. After co-registration, they are matched together. And as I said, it's very important to always do a quality check on the output. Then we will use the subtraction routine, which, as I said before, was written by Professor Patrick Dupont. This entails several steps. So what we want to do, if we want to subtract the ictal and the intra-ictal scan, we only want to subtract the brain volume. So we're not interested in extracerebral activity. So you need to define a brain mask. So you can either load a separate brain mask if you have one. What we use, actually, we use a threshold of 30% of the maximum value. This works in 99.9% of the cases. This works fine. But it could be dependent on like a lot of things, and I think in the first place on the tracer used. It's known that the ECD tracer has less extracerebral uptake than the HMPO. So if you use a different tracer, this threshold of 30% might not be sufficient or might not work. Then you have to normalize your scans to compensate in the first place for differences in injected dose, or to compensate for like global perfusion changes, because in our center, generally the intra-ictal scan happens several weeks after the ictal. And we do this by proportionally scaling to the total brain counts. So you actually get a relative scan. So you can scale to the total brain count or to a reference region. We take the easiest option is to scale to the average value of all the brain voxels. Then you subtract only those voxels which are in the measured volume of both SPECT scans. So this again entails this brain mask. Then you smooth to increase signal to noise ratio. We smooth using a Gaussian kernel of 15 millimeters. Then you have the different image, and then you want to transform it into a z-score. So our difference image is ictal minus intra-ictal, and then we take every voxel value, the z-score of every voxel value is the voxel value minus the mean of all voxels divided by the standard deviation. And this creates then a z-map difference image, like is shown here. So also if you have this difference image as an output, you can also verify whether the brain mask these 30% thresholding, if this was sufficient or not. So then if we run this, so we call the routine, and then it will ask you for these input parameters, which the ones we are using are the standard ones, or so the amount of smoothing is 15 millimeters. Then it asks, do you want to normalize by proportional scaling? And in our case, we say yes. It says here, do you want to use a mask to determine the brain voxels? The standard answer is no, because we will use this threshold of 30%. And then it will ask, select two images to subtract, so image 1 minus image 2. So we take the co-registered ictal scan, so the R ictal minus the interictal, done. And then it, you see here that the output was the diff Z image. And you see here as also a kind of quality check, a histogram of the z-scores that are in the subtraction image. So you see already here that there is like a bit more in the hyperperfused side. And this histogram should always be a more or less normal distribution. So if you here get something that doesn't look like a normal distribution, it means something went wrong. So either it's the mask or it's the registration from the ictal or interictal scan, but this should be resembling a normal distribution. So then we check the images. So we open again the interictal scan, and then we can overlay the diff-set image, and you overlay it in the positive values, positive z-scores, and the negative z-scores. And by doing this, you can appreciate the brain mask. So you see that this 30% masking worked quite well, worked very good for this patient. And you can already appreciate that there is here a big blob of hyperperfusion in the right temporal lobe. So this for the subtraction. Then the last step is to co-register to MRI, which is basically the same step as we did before for the interictal, the ictal and the interictal. So before co-registration, right now in our folder we have an interictal, we have the R ictal, and we have the diff-set image. We have an MRI. Then we co-register the interictal to the MRI and transform and apply the same transformation matrix to the R ictal and the diff-Z scan, which will give you as a result like both the MRI, the interictal, the ictal, and the difference image in co-registered, matched to each other in the same space. I always use the interictal to co-register to the MRI for the exact same reason that for us the interictal scan always has a very good quality. You don't expect like very big asymmetries or lateralizations in this scan. Generally this works. If it doesn't work, and this is also how it is described in the manual that comes with the subtraction script, you can make an average image between the interictal and the ictal and use that one to do the co-registration. To be honest, in the 7 years that I'm doing this, I never had to make this average image to make the registration work. So that's why I stick with using the intrarectal scan. So then we will do this. I will clear my workspace. I will call SPM. And we go back to the co-register estimate and reslice menu. So the reference image is now the MRI. The source image is the intrarectal scan. And then we have other images. These are the images that need to remain in alignment with the source image. So this is for us the R-ictal and the difference image. And then we start this batch. We can close the batch editor. So in theory, all these steps could be automated instead of doing it manually step by step. If you would automate it, I think you have to be aware and you have to be very consistent of keep on checking the in-between steps and the in-between output images. In our center, we generally have one intrarectal SPECT a week. So we analyze only one SPECT a week. So I think doing it manually might be equally fast. If you plan to do it research-wise, it might save you a lot of time to have it automated and to make it into a loop. But then be aware that you do a decent quality check from all the images. So here now we have the MRI and the intrarectal SPECT that are co-registered. So I will close this and we can check the images. So now we overlay on top of the MRI. First, I always overlay the co-registered intrarectal to appreciate the co-registration. And you see here that it's perfect alignment. And then next we can overlay the difference image. So now this is the R diffs image. And again, you load it, put this in another color scale. So you load it once for the positive values, once for the negative values. And you see here the unthresholded syscom image, in which you also in this case immediately see a huge blob of hyperperfusion in the right temporal lobe. So if we threshold this at -2, I have to put here, at 2 standard deviations, both the hyper and the hypoperfusion, and we scroll through the axial slices, we actually only obtain like one big blob of hyperperfusion in the temporal lobe, extending to the insular cortex. So this is our syscom image. So then if we go combine the results of our syscom image, which is shown here, if we add it to the full pre-surgical evaluation, we have the preoperative MRI, which had the enlarged amygdala and the gray matter and white matter blurring in the right temporal lobe, which was confirmed by the morphometric analysis program. When we look at the FDG PET, we also see a hypometabolism in this right temporal lobe. If we quantify it using an anatomy-corrected asymmetry index, we also see hypometabolism in the right temporal lobe. And our syscom is concordant. The EEG was concordant and the semiology was concordant. So the patient underwent surgery. Histopathology confirmed an FCD type 2A. And the patient is seizure-free since the surgery. And here you see the post-operative CT scan. Then for the interpretation of the syscom results, in our center, the nuclear medicine specialists, they do the visual assessment. They are trained to do this. They are much more specialized than us to do it. And they run syscom analysis through the software packages that they are using. It's MIM Neuro. Then from our side, from the neurology department, I run the syscom analysis through the MATLAB routine that I showed you right now. Then I compare my results to the syscom results of nuclear medicine. And in the very rare case that this is not concordant, we discuss them together and we see how to which method failed and which method was more concordant with the visual assessment. So there we reach consensus about the correct syscom hyper and hypoperfusions. Then the syscom image has to be interpreted within the full pre-surgical evaluation. So this means depending on the modalities you use in your center, it's the MRI, the PET, EEG, semiology, the MEG or the electric source imaging, neuropsychology, clinical history, all of this together. Integrate all of these results, and in our center this is done by the epileptologists. So they combine everything and they come up with a hypothesis where the seizure onset zone or the potential epileptogenic zone of this patient is. And then every month we discuss this in a multidisciplinary team meeting where everybody who is involved in the pre-surgical evaluation and the surgeons are present. And there all of these results are discussed to come with hopefully a solution for the patients. To interpret the syscom results, you have to be aware that the largest and the most intense ictal hyperperfusion cluster does not always reflect the ictal onset zone because it might also contain propagation patterns. So that means that you have to interpret the full pattern of hyperperfusion and not just search for the biggest or the most intense cluster that you find. So here are some examples from our center that were published like in 2007, 2006. So this was a patient injected during a focal impaired awareness seizure, injection latency of 18 seconds with a seizure duration of 70 seconds. Patient had presumed focal cortical dysplasia right here, and it's colored, manually delineated here in green. This was the syscom activation, so the hyperperfusion. And you see here that actually the blob with the highest hyperperfusion and the biggest is not coinciding with the focal cortical, the probable focal cortical dysplasia, but this will reflect propagation. So the patient had surgery from this part and was rendered seizure-free. Similar case, patient was injected during a focal impaired awareness seizure with injection latency of 10 seconds and a seizure duration of 46 seconds. Had a probable focal cortical dysplasia on MRI here. And you see that concordant with the probable FCD, there was a cluster of hyperperfusion in the ictal SPECT, but there was a much bigger and much more intense blob more posteriorly. So if you look at this image in an axial view, you actually see different blobs. And if you don't know the results or the conclusion from the MRI or the semiology in the EEG, there is no way you can interpret this image. Also, if you lower the threshold to, for example, 1 standard deviation, you actually see that these different blobs of hyperperfusions, that they are actually one network or one propagation network. So here the hypothesis was that based on the multimodal imaging and the integration of all the clinical information, that this was the true ictal onset zone. Patient had surgery and was rendered seizure-free. Then there is the question, which is the optimal threshold of your SysCom images? There are papers who are suggesting that 1.5 standard deviation is more sensitive than 2 standard deviations. In our hand, several years ago, we retrospectively checked for 80 patients, which gave 92 ictal SPECT scans, all patients that were seizure-free 1 year after surgery. And SysCom images were given to 2 blinded readers, 2 experts in nuclear medicine with like more than 10 years of experience. They were fully blinded to all the clinical information. The only information they got, whether it was a SysCom threshold at 1.5 or 2 standard deviations. Then if they checked that there was no significant difference in localizing the seizure onset zone, whether you use a threshold or 1.5 or 2, but the inter-rater agreement was higher at a 2 standard deviation threshold, and reviewers reported that they felt significantly more confident when they were interpreting a SysCom that was thresholded at 2 standard deviations. So in practice, we start with 2 standard deviations while integrating all the other clinical information and other image modalities. Like you can play with it. You can see. You can look at it unthresholded to see the whole network. So it's a bit patient dependent, I would say. So what is essential to know? You need to know the injection time relative to seizure start. As I said before, in some papers they say that injection earlier than 20 seconds after seizure onset gives the best localization. You also need to know like seizure duration. So this tracer kinetics we talked about, the image that you see is weighted on the first 30 to 60 seconds after tracer injection. And also as said before, extratemporal lobe seizure activity must last 10-15 seconds after the start of injection to be localizing. And you need to know seizure type, semiology, and EEG changes. So imagine you have a very, very short extratemporal lobe seizure, and afterwards, so you inject, a few seconds later seizure stops and the patient is confused and start moving. It can happen that you see mainly hyperperfusion around motor areas because of the postictal movement. So these are all things that you, when interpreting these SysCom results, you have to be aware of what was happening. And again, very important, you need to interpret in the context of the full pre-surgical evaluation. And maybe even more important, after quality checks of the images and all the analysis steps. So you need to know your analysis method. So you need to know what is happening during your analysis in order to be able to interpret the results properly. So then to end my presentation, I would like to introduce you to 2 more cases. So first is a 9-year-old boy with epilepsy starting at the age of 7. Semiology of the seizures reversion to the right, eye deviation, flexion of the right arm, sometimes followed by laughing or crying. This patient had several seizures a day. The intraictal EEG showed left frontal and frontal central spikes. Ictal EEG started also with rhythmic spikes in the left frontal central region. Then there was an attenuation, then there was a rhythmic beta activity with evolution to theta activity in the same region, and the seizure ended with high voltage delta and spike wave complexes in the frontal areas. MRI showed focal cortical dysplasia left frontal. So you see it here with an intenser signal on the FLAIR image and a blurry white, gray matter or white matter edge or junction in the T1 weighted image. So we obtained 2 SPECT scans. First scan was injected 16 seconds after seizure onset in a seizure that lasted for 23 seconds. The second was injected 5 seconds after seizure onset in a seizure that lasted 34 seconds. So in the first seizure, actually it was the grandmother who pressed the alarm button because she noticed the seizure. In the second injection, the second SPECT, one of the nurses was sitting next to the patient to be able to inject as early as possible. The second seizure had a longer duration and there was more motor involvement and there was some laughing involved as well. So if we look at the scans visually, you might see some hyperperfusion here, but there's also more perfusion in the right temporal lobes, posterior temporal lobes here. Maybe also here a bit more hyperperfusion in the right temporal lobe. If you look at the second scan, you might see maybe a little bit more perfusion like here on the right side as well. Here you have a similar blob of mild hyperperfusion in the same spot as the first one. You see mainly here involvement of like insular region, basal ganglia. If you look at the interictal SPECT, you see hypoperfusion in the left hemisphere, basically throughout the hemisphere. So this is like very hard to interpret what is going on here. So then we calculated the SYSCOM images, and I always show the unthresholded and the thresholded at 2 standard deviations. And you can see here in the first short seizure, the later injection, you see a blob of hyperperfusion which coincides with the focal cortical dysplasia. You see some smaller hyperperfusions on the other hemisphere. You can appreciate here from the unthresholded that this might be like one network of propagation. The second scan, we actually see also big hyperintense blob of hyperperfusion also around the focal cortical dysplasia, but we see a more extensive propagation pattern, also because this seizure had a longer duration and was accompanied with more symptoms, more like a more intense semiology. So if we combine it in the full pre-surgical evaluation, we have the pre-op MRI with which the radiologist detected a focal cortical dysplasia, which was confirmed by the morphometric analysis program. If we look at the FDG PET, we see a hypometabolism in the left frontal lobe, which is confirmed by the anatomy corrected asymmetry index from the PET. Here we only show one SYSCOM result from the earliest injection, coinciding with the focal cortical dysplasia. We did interictal source imaging, so the dipole localization was also in the area, in the same sublobar region as the focal cortical dysplasia. We did CLAHA distributed source model, which also coincided with the dysplasia. We did ictal source imaging, in which also both the dipole and the distributed source model gave the same results. And here is an image of the post-operative MRI where the FCD was resected. Histopathology showed an FCD type 2B, and the patient is seizure-free since the surgery. Then the last case, 25-year-old male, epilepsy started at the age of 18. Semiology, he reported a rising epigastric sensation, impaired awareness, occasionally tonic posturing, with a frequency of several seizures a month. Relevant history, he had 5 febrile convulsions at the age of 6 months. Intraictal EEG showed left antero-mid-temporal spikes. Ictal EEG also showed left antero-mid-temporal repetitive spikes with evolution to theta and delta activity. And the MRI showed a left hippocampal sclerosis. We obtained, again, 2 SPECTs. Here I show 3 minutes of EEG, so I squeezed in the seizure. Injection was late. We injected only 91 seconds after EEG onset, and the seizure duration was 3 minutes. And this was a focal to bilateral tonic-clonic seizure. So you see here on the EEG, you see seizure start, semiology start, and here is start of the tonico-clonic phase, and tracer was only injected during the tonico-clonic phase. So this is something that you have to keep in mind when you look at the images. Second seizure that we could inject tracer, we could inject 15 seconds after EEG onset. And the full seizure duration was 97 seconds, and this was a focal impaired awareness seizure. So here you see EEG onset, we have a fast tracer injection even before semiology onset, and here is the end of the seizure. So we have the 2 ictal SPECTs and the interictal SPECT. And if you have a very quick look at the first ictal SPECT, it's very hard to detect one region of hyperperfusion, so you mainly see changes here around like insular, basal ganglia maybe. Second SPECT, you also see some hyperperfusion here. There is like a little bit of asymmetry in the temporal lobes because we kind of know where we have to look at. If we look at the interictal SPECT, there are also not very pronounced regions of hypoperfusion, except maybe here in the this left temporal lobe. But based on this, it is very hard to draw a conclusion or to say where there are the regions of hyperperfusion. When we calculate the SYSCOM images, again, like the non-thresholded and thresholded at 2 standard deviations, if we look at the thresholded ones, we see here more insular activations. This was the seizure that was injected during the tonico-clonic phase. Second seizure had an earlier injection. We see also some insular involvement, but we also see here 2 blobs of hyperperfusion in hippocampus and temporal pole, which you can also appreciate here in the unthresholded SYSCOMs. So if we add it to the full pre-surgical evaluation, we know from the MRI there is hippocampal sclerosis. We did interictal source imaging, so the dipole modeling pointed to the left temporal pole. Also, in this case, we did a cortical clara as a distributed source model, which pointed to the left mesial temporal pole. FDG PET showed hypometabolism in the left temporal lobe in hippocampus, which was confirmed with anatomy-corrected asymmetry index based on the FDG. We did ictal source imaging, which showed similar results, left temporal lobe. We had the first SYSCOM, which was not localizing due to the late injection. And then we had the second SYSCOM, which was concordant with a left temporal lobe ictal onset zone. patient at surgery, you see here the postoperative CT, histopathology confirmed the hypothesis of hippocampal sclerosis, and the patient is seizure-free since surgery. So to conclude some key points, if you want to do ictal SPECT imaging, or if you want to start ictal SPECT imaging, in order to have good quality and successful, technical to obtain the images, you need a very close collaboration between neurology, the EMU, and the nuclear medicine department. Furthermore, you need highly trained and skilled EMU staff to recognize the seizures fast and to be able to do the injections. Then if you obtain good quality early injected images, then it's essential to use them properly. So to use them in the full pre-surgical evaluation and to know what you're doing. You have to know the methods you're using to analyze the scans. You have to know your patient, you have to know the semiology, you need to know how the seizure looked like, the one that you injected, you need the injection times, you need the seizure duration. And as I said, it has to be part of the big multimodal pre-surgical evaluation. If based on all of this, you might not come up with a clear hypothesis on where the possible epileptogenic zone for this patient is, you can use also these SysCom images. It will help you into have an hypothesis or have an implantation strategy for invasive monitoring. But this also, again, in the full multimodal workup. So to conclude, I would like to thank everybody who is involved in the pre-surgical evaluation program in our center, especially for this talk, Professor Patrick Dupont for sharing his script and his methods, and the nuclear medicine radiopharmacy department, because they are always very flexible to pause their clinical program and to scan our patients that we injected during a seizure. And of course also the people from the epilepsy monitoring unit who are doing the difficult task of recognizing a seizure and doing these early injections. So if you have any more questions after this talk, please feel free to contact me. My contact details are here below, and I'd like to thank you for your attention.